Welcome to Decoding Healthcare Research. I'm your host, Efrain Riveros, Dr. E.F. Rain. Today, we are going to focus on precision medicine. We will talk about circulating tumor DNA and the use of liquid biopsies in the context of cancer. So we have the honor of having here an expert. We have Dr. Christian Rolfo. He's the Associate Director of Clinical Research at the Center of Thoracic Oncology in Icahn School of Medicine in the United States, and he's also the president of the International Society of Liquid Biopsy. Welcome, Dr. Rolfo.
Thank you, Efrain, for the invitation. It's a pleasure to be here.
Thank you so much. So we are dealing with this topic as we are focusing on precision medicine, and one of the fields that is advancing at probably at the greatest speed is cancer. And we will discuss some historical aspects of, liquid biopsy and all these technologies that are becoming more widespread and also more useful at different stages of cancer, from screening, diagnosis, treatment, and detection of recurrence, and so on and so forth. So the first question that I have for Dr. Rolfo is, what sparked your interest in this particular aspect of cancer?
Yeah, so as you say, precision medicine or personalized medicine is growing very fast. So we are applying that since some years ago, especially in the area that I'm working, that is liquid biopsy in lung cancer. The use of technologies that allow us to do a molecular profiling of the patients, give us the opportunity to treat the patients with targeted therapies and understand better, for example, differences in populations to find the right treatment. So it's fascinating how we was moving this field very quickly. Actually, FDA was approving several drugs in very short time. And this kind of genomic tsunami information that was coming need to have a technology that is a companion for these kind of adventures that we are right now with precision medicine. So liquid biopsy as tissue biopsy are options that allow us to do this and get the profiling of the patients and much more information, actually.
Yeah, and traditionally, like in the past, for people who are not experts, we are used to the diagnosis of cancer with the tissue biopsies, right? But the advent of these new technologies, is interesting because obviously it's less invasive. But I want to learn from you how can you compare side by side what we call liquid biopsy with tissue biopsy?
Yeah, so just to start from a very simple definition with the liquid biopsy is simple blood draw. We are talking about liquid biopsy today in this podcast about the ctDNA, but everything that is fluid in the body can be used as a liquid biopsy, and that could be not only the blood. We can use the urine. We can use, for example, the CSF. We can use also, in case of milk, for example, from breast, as well as a source. And there are very interesting research recently published on that. So it's a very quickly field that we will use today, or we will discuss today, the ctDNA, that is the peripheral blood. So that is a blood draw. And from there, we have the opportunity to apply this analysis in different scenarios of the patient journey in cancer. Actually, we started all these adventures in advanced disease, and the first studies were more focused on what you was talking, the concordance between tissue and liquid biopsy. And there is an advantage and disadvantage from both sides. If we are looking, for example, tissue biopsies, we have obviously the pathological information. We have information about the tissue even, for example, in the case of immunotherapy, some biomarkers that we can do in immunotherapy. But from the other side, the tissue is sometimes in some tumors an issue. So we don't have the possibility to have a big quantity of tissue in all the patients. That's one. The second one is that when we are taking part of the biopsy or a piece of the tumor, it's only a piece of the tumor. So we don't have an information what is happening in other sides of the disease, for example, in patients who have metastatic disease. So from the other side, liquid biopsy, so we will not have in that case information about the clonal evolution of the disease or the heterogeneity that could be present in the disease. From the other side, liquid biopsy can capture that, is minimally invasive, but also is possible to be repeated over the time. And this is a very important concept because nowadays we are applying liquid biopsy in the monitoring, and that will be very difficult to do with the rebiopsy of the patients. So one of the advantages is that. The other advantage is that we have an entire opportunity to see clonal evolution and heterogeneity, because we can capture fragments of DNA that are not coming only from the primary tumor, but also from metastatic sites, and also some disadvantage that could be related more to the false positive or false negative. And in that area, we have, for example, in the false positive, some clonal hematopoiesis, so mutations that are coming from normal aging, and that we are accumulating during the years in our life. But the false negative, that was a problem sometimes with the technology, that now with the technology that we have, and we can discuss about that, is really a minimal problem in the false negative. One of the things, and we incorporate here another kind of definition, that is the tumor fraction, is a calculation that we are doing, a mathematical calculation coming from the aneuploidy of the cells. We can, from there, calculate if a liquid biopsy is informative or not. And we just published, and for the people who is listening to this podcast, you can find this information in a paper that we just submitted to Clinical Cancer Research and will be published soon, was accepted and was presented in ASCO this year. And we showed that with this kind of approach, you can really understand if a liquid biopsy is informative or not, if you need to wait for the tissue. But several studies were already demonstrated that we have a high concordance of tissue and liquid biopsy.
Yeah, and the potential for this technology is immense, and it's actually a reality nowadays. So what is exactly a liquid biopsy in terms of, what are they measuring in it? Is just DNA that is shedding from the tumor?
Yeah, so we are searching part of the DNA, fragment of the DNA, and with a technology that is called high throughput sequencing or next generation sequencing, that the NGS, the people knows this, majority of the people know this terminology. We are trying to figure out if there are different alterations there, genes, mutations, fusions, depends on the technology that we are applying. If we want to have an enrichment technology, for example, for capturing more fusions, like we are doing RNA as well, sequencing in some cases, or we can do a high throughput sequencing that is another, a hybrid capture that is also an opportunity to capture more fusions. So you can capture the fusions, and according to the quantity of DNA that is present in the sample, and that is another definition, is the variant of allelic fraction. You can have there the quantity of DNA that is present, this mutation or this alteration. In lung cancer, so in lung cancer we have a lot of patients with different populations. For example, EGFR mutation that could be present according to some ethnic groups. For example, in Asiatic population, 40% of the patients with lung cancer could have these mutations, so it's important to capture that. Latin Americans as well, for example, Peruvians or Mexican, 40% as well of this prevalence. And so it's a very important tool to not only to diagnosis, but also to monitoring or assess the response to the treatment that we are starting.
Yeah, it's very interesting how you can use the technology not only for diagnosis and screening, but also follow up and even after treatment. So, and before we go into that, has it been used in every type of cancer, both solid and liquid tumors?
Yeah, there are platforms for both. Lung cancer, that is the area that I'm working on, was the perfect scenario to start it because we have an explosion there of biomarkers that were found in tissue. So it was the perfect scenario. But nowadays we are applying this in breast cancer. We are applying also colorectal cancer, and even hematological tumors have different platforms. Sensitivity and specificity could change a little bit in some tumors because obviously it will depend on the vascularization, the size of metastasis, and other kind of factors. In the case of primary tumors in the brain, that's a little bit more complicated to go for peripheral blood, but we have also other technologies or other techniques that we can afford also this hematoencephalic barrier as well.
I see. In the context of lung cancer, that is your field of expertise, how pervasive is it in the screening and diagnosis and also follow-up of cancer? Is it being used like everywhere in the United States nowadays, or is just starting?
Yeah, so that's another interesting point because, as I say, we started with all the accumulation of our robustness of our data in the advanced disease. In early disease or early detection, we are still in a very preliminary step. So we have some technology that is commercially available that is using methylation of the ctDNA. And that's an approach that is a multi-cancer detection test that have still a very high sensitivity, specificity, but the sensitivity is not so high. So we are talking in the data that were presented in the validation in all the tumors, including some hematological tumors, around 16%. In stage 1, that is the stage that we want to capture the cancer. Obviously, if we increase the stage, and so that we increase the tumoral burden, the possibility to capture there more patients is much easy, we would say. There are other approaches that we are using also in early detection that are beyond the ctDNA. But at the moment, I think we need to have still some data more robust to start to use that. There is not still a method that is FDA approved. We have methods that are commercially available. But I say we need to be a little bit more responsible to use these kind of technologies because false positive could be something that we can see, and is important to distinguish that and be responsible what we are discussing with the patients in terms of results.
So recognizing the limitations and specifically that the rate of false negatives that can be concerning, especially if you are screening a patient, how do you envision this technology to actually change the approach that we have to cancer, specifically lung cancer?
So in an ideal world, I would like to have a technology in early detection that is able to be a companion for screening programs. So we are using, for example, in lung cancer, low-dose CT scan screening, and having some technology that is able to increase the rate of sensitivity to find these patients, increasing the performance of the low-dose scan screen will be fantastic. But also, I would like to have a technology that is able to stand by themselves, to have a liquid biopsy that is able to pre-screening these patients. And especially, we need to remember in lung cancer that 20% of our patients are never smokers, and they will not enter in programs of screening. Or even with the limitation of screenings, that thanks for the new rules, we can include more patients because we reduce the age to inclusion of the patients, the time, the exposure to the smoking. So these are things that are helping, but not in every country we have the opportunity, or not in every state, even in the United States, we have the opportunity to include all the patients in the screening program. So having a technology in liquid biopsy that is able to diagnose the patients in the very beginning is fascinating. Still, we need to have more work in progress, and I think that there are some platforms. Some options could be also to have a multi-omics approach, not only ctDNA methylation, but also multi-omics approach. And there are some companies that are actually working, and some researchers that are working in proteomics, metabolomics, and other sources that we can get from the circulation.
Yeah, and I am sure that combining all these aspects of the omics approach, we are going to improve the performance of these screening tools. And I see that this is growing, and you are actually leading the way, specifically in thoracic cancer of the lung. My next question is, you have like a vision for this to advance, but at the same time, I assume there are some barriers in terms of the healthcare system and maybe some ethical concerns. Are those something that you have in mind when you think about future research?
Yeah, I think there are areas that we need to advance. One of them is, for example, minimal residual disease or perioperatory scenario, where we have patients that are going to receive treatment for reduce the tumor, what we call neoadjuvant treatments, or patients that were resected in the tumors and they have the possibility to capture when these patients are progressing, that is an adjuvant setting. So these scenarios are very important because we can really increase the possibilities of cure in some cases, and this is very, very fascinating. So I think the research needs to focus in the inclusion in clinical trials of liquid biopsy in the proper way, in the design, I mean, and in the technology. We see nowadays that several trials are still missing. When we have the data presented, we are still missing the data of the liquid biopsy, or we are accumulating a lot of samples, but we don't know what we need to do with this technology because technology is evolving. So it's really important that researchers are working with experts in liquid biopsy to advance the field. So that will be one of the considerations. Another aspect in the research of liquid biopsy is the understanding of the biology process, and that we are talking today as ctDNA, but there are also other analytes of liquid biopsies like CTCs, like exosomes, like platelets, that can help us to understand a little bit more of complex process like metastatization or even mechanism of resistance, or even in the research of new biomarkers. So that's our areas that need to be also very, very hard supported. And it's difficult sometimes to have support for research in these areas because are areas that seems to be not so fashion at the moment when we are talking on liquid biopsy outside the ctDNA. So that would be maybe important to emphasize.
Yeah, so there are also barriers in terms of funding. And what about access of patients to these
Absolutely.
technologies? Is this something that is problematic nowadays?
Absolutely. So in United States, we are very lucky to have the reimbursement for majority of the insurance companies, of the vendors, of the platform from the vendors, commercial platforms. And we have actually a very good network for commercial platforms available. So you can choose different opportunities. In other countries, like in Europe even, for example, we don't have access to all these vendors' reimbursement, so that's a very important barrier. And from the International Society of Liquid Biopsy, we are trying to try to erase these inequities that we have in access. Several countries are working specifically in platforms that can be reimbursed. For example, Belgium, France, they have some platform. Spain is working on that as well. So having small platforms that can allowed to have minimal information of the patient's in-house platform, but that will need also accreditation of those labs and quality controls to be sure that we are giving to the patient the right reporting. No, so try to avoid this. But also from another side, the access is depending not only in the economical barrier, but also in the education of the doctors and the providers. For example, we don't go in so far. In America, 50% of our patients, according to the My Lung Consortium presented 2 years ago in ASCO, are only 50% only are tested in lung cancer. And we have access to the technology. So that means that we are not really focused in the education. And if we are looking, for example, some special population groups like African Americans, 39% of the patients were in this survey tested. So we need to do better in testing, and that is depending on education as well.
So that means that most of the efforts to introduce the technology are focused on screening. Is that right, or is widely used throughout the spectrum of treatment follow-up? What is the majority of cases are benefiting from what part of the?
No, I think at the moment we need to we have the approval and is widely used for metastatic disease, and there we can impact because we know, for example, in lung cancer, having the molecular information of these patients with the stage 4, we can have actually a treatment that is in first line. We are now moving, as I say, the gears to minimal residual disease. That is also another scenario. We have commercial platform also available there, and there are several studies running at the moment on that. So the application of liquid biopsy will be growing and growing. And this is need to be followed by education to all of the doctors, not only oncologists, but also making sure that the importance of having this profiling is coming even from the clinicians that are the front line of patients' care. We just published also in JCO Precision Oncology another paper this week that is regarding to the use of liquid biopsy before we have the pathological information. This is a kind of exercise to try to understand if we are incorporating liquid biopsy in the staging of the clinical diagnosis of lung cancer, we can reduce the time to access to the treatment. And in this exercise, we saw that the patients who have this kind of approach, where they were able to be identified at least 36% of genomic alterations that could be targeted with new treatment. So this recuperate a lot of time for the patients to access to the treatment when we have directly the diagnosis in histology later on.
I see. One important aspect when I was going over the paper, I have some concerns about the heterogeneity of the tumor cells within a solid tumor. So I assume that you may not be able to capture that heterogeneity with a liquid biopsy. I assume it depends on the anatomical location of the organ affected, probably some changes in the temporal framework. So this heterogeneity of the tumor, is this something that can be addressed, that limitation with the liquid biopsy?
Yeah, it's a limitation that we have with the tissue biopsy as well, because in tissue biopsy, and I explain that to my patients, like when you have a piece of cake with these different flavors and I only make you taste the chocolate, you will say that 100% of the cake is chocolate. But so we need to try to understand and capture the other flavors. And that with liquid biopsy, we have partial of this information. Obviously, it's not, we don't have a 100% ideal tool in any both of neither of both, so not in liquid, not in tissue, but we have a more opportunity to capture fragment of DNA coming from different location of the tumors, and that is happening also to see, for example, commutations and information that is really important for the patient care.
Mm-hmm. And it's fascinating to see what you guys are achieving in this field, and it's really revolutionizing the approach to cancer, and it also is giving hope because I am sure that more patients are going to be like detected earlier, and their outcome is going to be better, leveraging on this technology. Because this is a growing field, what do you think is the most important knowledge gap that needs to be addressed for this technology to become more widespread and more applicable to all the field of oncology?
Yeah, I think we need to tackle education from different areas or different point of view. One is to educate the community, the patients, why it's important to have liquid biopsy. This is not experimental. This is something that is applicable, it is approved, and we can use that. So when you are having the conversations with the doctors as a patient, try to bring to the table that even if your doctor is not bringing that. So this is one part. And there are several advocacy groups that are working very hard to educate patients and make aware the patients, because they are the power of the voice. They have an important power of the voice for bringing this on the table. The other aspect is the doctors and the healthcare community, and they are. I'm not talking only about doctors. I'm talking also about nurses, nurse practitioners, physician assistants, and all the healthcare team that is working on that, and knowing that this is a very important step. And we need to use it in the proper way. So, for example, when we have a patient with lung cancer with a new diagnosis, everybody wants to start very quickly the treatment, but waiting results for liquid biopsy liquid or tissue biopsy is really important for the molecular profiling. So having this information is very important. And second one, we need to educate institutions or also insurance companies, why this is important. So in some areas of the country, I have some discussion with colleagues that they are really concerned about the approval process of some insurance companies. So this is ridiculous that in 2023, 2024, we are talking with companies and try to explain why it's important to have a molecular profiling. Because we have from other side, FDA, pushing for approval of different drugs, and that's an important moment that we are living in oncology. So we need to be all together working in the same way.
Yeah, you touch on a very important point. So education and basically spreading the word. And I think part of the goals of this podcast is to bring this information to interested parties, not only practitioners, but patients alike. And I want to close by asking you, what do you think is the takeaway for practitioners and for patients based on your experience and your research?
So my take-home message would be that liquid biopsy, first of all, is a high concordance in tissue and liquid biopsy. So we are already applying this in the clinical practice. It's not experimental. The second one is that liquid biopsy could be a perfect tool for monitoring response, not only identification of drivers or mechanisms of resistance, but also monitoring of the disease. The third one, that we need to apply this in clinical trials properly. And the fourth one is the education. So testing the patients is the most important application that we can have.
Excellent. I think the message is very clear, and I think this is one of the aspects that is growing like in the fastest way compared to other fields of medicine. And I am excited to having had the opportunity to talking with you as you lead the way in this particular topic. I want to thank you for being here with us today. And I am sure that our audience will enjoy greatly our conversation. Thank you so much.
Thank you very much, Dr. Riveros, and it's a pleasure. If somebody wants more information, we have our website from the International Society of Liquid Biopsy, that is islb.info. And our annual congress this year will be in Denver, Colorado, on 23 to 25 November. So you are all invited, and in the website you have all the information. Thank you very much for the opportunity.
That is great. And in the description of the video, you are going to find the link to the paper that we discussed today, as well as the website that Dr. Rolfo just mentioned, and also the website for the meeting. Thank you for sharing this time with us today, and see you in the next episode.